Okay, back to the colonoscopy decision tree. Now, first off, I just want to point out this decision tree is found in your standard 2015 CPT codebook on page 200. So feel free to write in it or anything to make note. Also, there is a revision that came out because there is a mistake, believe it or not, in the CPT book. This section right here, if it says to add modifier 52, just cross that off. There should be no modifier. You would not add a modifier to this section. So, again, coding for colonoscopies can be challenging. In order for a colonoscopy to be a full colonoscopy, the surgeon must reach the cecum. Otherwise, it is coded to the extent of the procedure, but if that surgeon gets beyond the splenic flexure, but does not make it to the cecum, then the coder is going to be in this middle section. The first thing the coder really wants to determine is, was it a diagnostic colonoscopy or was it a therapeutic or surgical colonoscopy? So did they remove something? Are they just inspecting, exploring? Maybe they did not remove anything. If they did not remove anything and patient had a healthy colon, they did not need to remove anything. But sometimes if there is not a good bowel prep, the physician or surgeon cannot get past and does not even reach the splenic flexure, makes it to the sigmoid area and has to abort the procedure. If that happens, the coder is going to code to the extent. How far did they get? In this case, it would be 45330. But say the surgeon got beyond the splenic flexure, but still did not make it to the cecum. The coder is going to choose 45378 for a diagnostic colonoscopy with a modifier 53 to indicate that this is a reduced, discontinued service. If the surgeon did make it to the cecum, then the coder would just code the straight colonoscopy procedure with no modifier. If the surgeon removed polyps, maybe did a dilation of because there was a stricture there, or they performed some other kind of surgical procedure, the coder is going to be on this side, and it's going to be the same as the left side. Depending on if they did not reach the splenic flexure, they're going to be in this code range. If they did reach the splenic flexure but not the cecum, they're going to be in this code range, the 45379 to 45398, depending if they did a polypectomy, if they just did a biopsy, what kind of biopsy did they do, and they would add a modifier 52. Now you could be asking yourself, why over here is it a modifier 53 and over here it's a modifier 52? I will go over that in just one second. And again, here's your, if they made it to the cecum, you're just going to be in the same code range, but of course without the modifier. There's a lot of question that goes on. When would the coder use a modifier 52 versus a modifier 53? If the intended procedure or surgery is completed, but the description of the intended and the completed intervention is less than any defined CPT code, modifier 52 would be used. So we're going to use modifier 52 on this side because they actually, in here, they did a colonoscopy and they did remove something within this section. So a modifier 52 would be used on this side. If the procedure or surgery was unsuccessful, incomplete, discontinued, aborted, that's where modifier 53 is going to come into play. Again, there's still a lot of discussion between 53 and 52. So as we're going through exercises and examples and stuff when we work together during this section, we'll try and do some more highlights with some scenarios as we meet. Just real quick, also, this decision tree, this is just for Medicare patients where G codes are used. Same scenario, just for G codes.